This is a reconstructed video based on a live audio recording of a talk I gave in Istanbul in May 2023.
Merhaba. I'm afraid that's all the Turkish that you're going to get from me. So we'll be in English for the next 15 minutes. It's a real pleasure to be invited back. Thank you to Ona, Tarek, Adam, for inviting me back. We, myself and some colleagues from Oxford, had a wonderful time together here back in February for a course at RMK Ames. And it's a real pleasure to be back with the IURES Congress. And I hope that the topic that I'm going to spend the next 15 minutes or so talking about might be a good example of what Ona was saying with the research factory about constructing and planning a good project, having an important idea, and then working out how to undertake quality research. So I think it will fit quite well with the kind of example that you were suggesting, and hopefully that'll become clear as I talk. So the title I've been given to address is Germline testing in prostate cancer, to whom and when. Now, the only slight problem is we don't know very much about to whom and when to germline test in prostate cancer. So I'm going to be slightly naughty and spend most of my talk addressing somatic genetics in prostate cancer rather than germline. It'll become clear, hopefully, after my first slide, why that's the case. So what is germline testing? Well, let's just remind ourselves, I'm sure everyone here is familiar with what we mean by germline. You see, germline genetics are the genes that are inherited by each of us through the initial cells through the zygote, so the egg and the sperm. And so these are genes that are present in every cell in our bodies. A couple of definitions there. So they are cells that form the egg, sperm, and fertilized egg. Series of germ cells descended or developed from earlier cells. So the inherited genetics of the human form. And really in prostate cancer, and I think it's great to have this at the start of a session on prostate cancer, because I hope with what I'm going to show shortly, it'll become clear why this does underpin most of the clinical management and research questions in prostate cancer. But in prostate cancer, really, there are only two areas of germline testing that we know anything about. And these are SNPs, so single nucleotide polymorphisms, which are single base changes that are inherited. And in prostate cancer, Ros Eels, in many, many Nature Genetics papers, has published now about 172 of these, which are thought to be linked to prostate cancer risk. Furthermore, SNPs have been incorporated into the Stockholm 3 assay, which some of you might be familiar with from a Lancet Oncology paper just last year from Henrik Gromberg in Sweden. The other area where germline testing has been incorporated is in the DNA repair defects genes, so BRCA1, BRCA2, ATM, Fanconi genes. These have been shown to be a significant risk factor for aggressive advanced prostate cancer, with some nice papers over the last 5 to 6 years, particularly one in the New England Journal of Medicine from a colleague in London called Joachim Matteo. But to whom and when might these be used? Well, I have to say that for SNPs, we really don't know. The Stockholm 3 assay has been proposed to be used in screening, potentially also to assist us with active surveillance decisions, but it certainly hasn't made its way into any guidelines yet. As for BRCA2 or DDR genes, there is a little bit more evidence there. They can be a useful companion diagnostic for PARP inhibitors, which are increasingly being used in the advanced or metastatic CRPC setting. So really, I think that's all we know so far about germline genetics, and I'm not going to speak any more about it. if that's okay. So now we move on to somatic genetics. So this is genes that have mutated after the germline has been established. And the reason this is important is that we have a big problem with prostate cancer. And it was most supremely demonstrated, I think, by our head of department, Professor Freddie Hamdy's paper, which those of you who were at EAU, so this was about a month after we were all here from Oxford in February, published the 15-year outcomes from the Prostate trial. And this demonstrated, perhaps surprisingly, that for men with low and intermediate risk prostate cancer, and indeed a third of these men by modern classification did have high-risk prostate cancer based on T3 staging, it makes no difference whether you treat these men or not. And by not, I mean enrolling them in a comprehensive active surveillance program. But of course, the caveat there is that 61%, in my tweet I put 62%, 61% of these men did transition to treatment during the 15 years of follow-up. So it does look like active surveillance for all these men could be a good option up front. In other words, the overall survival doesn't change, but clearly some of these men do require treatment. And I would suggest that we're still not very good at working out which those men are. Why is that? Well, it's because of prostate cancer heterogeneity. So here's the problem that we've identified for a research factory project. Prostate cancer is heterogeneous. How can we understand it better in order to make intelligent decisions about how to treat it? This is a little systematic review that one of my postdocs published a year or two back in European Urology Oncology. And really, it's just meant to outline the nature of heterogeneity in a cartoon form, both in the organ itself on the left, and also in terms of metastatic disease. And the colors here are meant to demonstrate somatic genetic mutations that lead to clonal changes. And you can summarize that in another way, like this. These kind of fishtail maps are about clonal disease burden. So the idea is you have a genetic mutation, more than one almost certainly in prostate cancer, which leads to development of a cancer cell, which then divides, expands, and gives rise to a tumor. You can get polyclonal mutations, so that's the yellow, the green, and the blue occurring at different time points. And you can get subclonal mutations, which is where a further mutation occurs on top of those that have already occurred. For example, the orange. Now, we need to understand this if we're going to treat prostate cancer effectively. Why is that? Well, because if we do a radical prostatectomy where the kind of big line cuts it off and get rid of everything, but there's already a micrometastatic clone that's left the prostate, then we're not curing prostate cancer, and the Halstedian model of treatment has failed. Of course, an alternative would be the positive surgical margin, as we see in the blue fishtail, and of course, we're all worried about that too. So how are we going to investigate this? Well, let's start by seeing if we can understand properly the clonal composition of the primary prostate cancer. And I'm actually just going to show you, this is a work in progress. We've got a couple of nice papers out of the project so far, but I'm just going to show you this sort of vignette really in the rest of my time. And you'll have to invite me back on another occasion to tell you where we've taken this in the last couple of months. So how can we characterize what's going on in the prostate itself? Remember the blue and the green and the yellow and the orange, okay? So for example, let's just hypothesize they could have these different grade groups, 1, 2, and 3. Which matters? Well, we'll come to how we work out which matters, but first of all, we need to know what is what in this prostate. And let's remember that this prostate exists in a context, and from a clinical management of prostate cancer perspective, we want to know, ultimately, is this likely to spread to the lymph nodes or to the bone? So, which of these particular clones matter? Well, is it this one? Is it the positive surgical margin? We generally think that it is important, don't we? So, is this the area that spreads to a lymph node? Possibly. Possibly not. What about this little bit here? it's not invading into the capsule of the prostate, but it's a small area of potentially high-grade subclonal mutational development, which could be really significant. Perhaps that's the bit that spreads to the lymph nodes. What if we get further development of subclonal mutations? So let's go from orange to purple to red within that lymph node, and that's the bit that spreads to the bone. If we don't understand this, we're essentially undertaking a futile treatment process and not doing our patients a good service. So, like I said, our priority in the first instance is to work out what's going on in the prostate. This is how we do that. I had the pleasure of meeting a senior colleague of Erdem's a moment ago, who I think is a retired pathologist, and all of this work is contingent upon very good pathology. The way that we do this is we, in the first instance, take an axial disc from the central part of the prostate, and with this example, this is a real patient of mine's prostate. We see, as we often do, multifocal prostate cancer. And I'm not going to show you all the details of this, but you can take it as read that there are many different grades within that prostate. And we are now using a technique called spatial transcriptomics to address this. So this is where we've identified an approach, a platform, which can help us to address our research question. And this schematic is a figure from our paper, but it summarizes quite nicely what we've done. So we take that disk, we divide it into cubes, we take those cubes and apply them to this spatial transcriptomics platform, which has three important layers. One is the observed transcriptome. So just a quick reminder, this is the mRNA, where DNA is transcribed, which gives the messages that are required to make protein, which is what actually does the job of a cell. So it's a good insight into what's actually working within the cell. So spatial transcriptomics, the mRNA, and then we infer the genome. That's the spatial IC&V, copy number status. And underpinning this is consensus pathology, very, very detailed granular pathology from 2 or 3 pathologists. And it enables us with these spots, which are small to the extent of 10 to 15 cells, to identify which clone these different cells, cancer cells or benign cells, belong to, and then construct these clone trees. And if you want, you can find it in Nature from last August. So, here's the prostate divided up into these cubes. It's a little bit messy. It's a difficult technology to use, but we're getting better at it. This one was a couple of years ago. But you can see here the histological composition of this prostate. A typical prostate, multifocal, 2 sites, particularly right and left, and interestingly, a grey group 1 region at the bottom, which I'll come back to in a few minutes. So we're just going to focus in the next couple of slides on one section, H21, which has, interestingly, some intermediate grade, that's the dark red, some high grade, as well as some PIN and some regions of benign prostate tissue, which is the blue area. This is how that looks at a spatial transcriptomic level. So each of those spots, and there are 4,000 spots here, has a whole transcriptome. So effectively a whole DNA sequence for every spot. Remember 20 years ago, for the first human genome, one genome cost hundreds of millions. Now we're able to do a whole genome effectively on every one of these spots, and it takes less than a day to run this. It's still quite expensive, but it takes less than a day. And what we can do is then look at each of those spots and derive the genomic status, the copy number status. This is just a heat map, but basically all the rows refer to a spot, and the columns are the genes. So from gene 1 through to, as you can see, 22, and then the X and Y chromosome. And so we can then work out, according to those color charts on the right, which clone, basically it's like a fingerprint, which clone do these spots belong to, and then map that back onto the histology. So I just want you to remember that this region here is blue for benign, okay, and just keep an eye on yellow clone C, and then these ones E, F, and G. Okay, there's not much going on at the top in green. So the blue area that's benign is actually surprisingly not normal. C, clone C, which is benign, remember, has a lot of the mutational events we would normally associate with high-grade prostate cancer. And then the cancer regions themselves differ. particularly look down at G here, which has developed a further mutation again in chromosome 7, the subclone, if you remember from my cartoon at the beginning. So now, using this technology, we can unpack what previously would have been sequenced as one big chunk of tissue into several thousand smaller chunks and allocate them to clones. And this is now enabling us to unpack what's going on with the clonal composition of prostate cancer, because we can construct an ancestral or phylogenetic tree and then work out which clones have mutated, possibly given rise to an alternative bit of cancer, or developed further subclones, which could be the ones that spread. I'm afraid I'm not going to show you that data because it's not published yet. Not that I don't want to show you, but we just don't have it properly formatted yet, because literally it's been something we've been doing in the last week or two. A final penultimate slide then on low-grade prostate cancer, because this is a project that Tarek and I are particularly interested in. So we noticed that that area of yellow, the grade group 1 tumor, doesn't have most of the events that we saw in the previous slide. I don't know if you spotted, but chromosome 8 had some losses and gains, copy number loss in blue, copy number gains in red. Those are what we consider now to be pretty sort of consistent with aggressive disease. They're just not there in low-grade cancer. So that's interesting, isn't it? Possibly grade group 1 cancer just doesn't have the ability to further invade, or does it? This is the question, isn't it, Tarek? So to that end, we've been considering a project that we could undertake to address this question. And so we've been having some discussions, Tarek, myself, Nathan Lack, with support of others, further to our wonderful meeting back in February, to see if we could get a joint project, if Tarek can find the funding, to study this in particular, because Tarek presented a super interesting case in February, which to my knowledge could be summarized by that cartoon, in other words, all grade group 1 at the prostatectomy, and yet developed a neuroendocrine metastasis sometime later, I think a couple of years later, which shouldn't happen. We now have the tools to interrogate this. So here's the question. Did that happen because it spread from an area of grade group 1, which would be vanishing unlikely, but it's possible? Or was there an area of non-transformed benign tissue which had neuroendocrine features? That's possible, but it wouldn't have probably been spotted by the pathologist. Or indeed, was there a subclonal development within the grade group 1 region, which was too small to spot at histopathology analysis? These are the kind of questions that now we can answer, and we're going to hopefully try and put together a great project to address this. Finally then, this is important for clinical decision making. I take it most people here are surgeons. Yep. So we want to know whether we should cut out prostate cancer or possibly not cut it out and do something else. So is this what we want to do? Remember that positive margin on the other side? I think the third talk today is all about prostatectomy and how to do that well. So this is why I'm saying this will inform that. Do we want to go wide on that side with a positive margin? Maybe actually that doesn't matter. Maybe it's the other side that we need to go wide on, because there could be some small cells that have spread, we can't see them, and they're the ones that are going to metastasize. What about focal therapy? Is that the region that we need to treat? Or maybe it's that region. We don't know yet, but I think we now have the tools to address this. Here's another problem. We think it's possible that these high-grade regions of subclonal mutation, actually, I take that back, they may not be high-grade yet, but they have subclonal mutations, could, I hesitate to use the word metastasize here, could seed within the gland. Those lymphatic channels, those blood vessels, they don't stop when they reach the prostate capsule. They carry on through. So it's conceivable that the gland has metastatic type deposits within it. This is clearly important for the concept of focal therapy. And it's also going to be important for our medical oncology colleagues who want to consider neoadjuvant therapy. So, I'm not sure how much time I have left. I hope that I have long enough to show you a 4-minute video. Thank you. So, on my YouTube channel, there's various things to do with the science that we do, and obviously some surgical stuff as well. And I just want to show you for 4 minutes one video that we produced, which I think will kind of show in the global sort of, in a broader scale, why we like doing this and opportunities to collaborate. And then I'm finished. That's my group in Oxford yesterday, actually. It's a bit blurred. We haven't managed to get the final photo yet. I'm not going to read it out. Thank you for having me. And you'd be welcome to join us in Oxford at some point. Eljad, you're coming to Edinburgh, I think, in May. Come and visit us in Oxford on the way down. I trained in Edinburgh. Here's my acknowledgements. Thank you very much.
Thank you very much.